Hi guys, my name is Sarah McSpadden, and today I'm going to talk to you about vitamin D and systemic lupus erythematosus, associations in genetic, epigenetic, and autoimmune responses. So a little introduction about systemic lupus erythematosus, otherwise known as SLE. It is a chronic inflammatory disease that is caused by autoimmunity. It's marked by the presence of anti-nuclear antibodies, as well as other signs and symptoms. So these are going to include low-grade fevers, photosensitivity, which will also have an effect on wound healing, ulcers of the mouth and nose, muscle aches, joint pains and arthritis, as well as fatigue, loss of appetite, a very distinct butterfly rash across the nose and upper cheeks, and inflammation around the lungs and heart, and lastly, as well as poor circulation through the fingers and toes. This disease is most commonly seen in women and those of African descent, and actually 90% of diagnoses are seen in women of childbearing age, which is why treatments can be so terrible. Either steroids, anti-inflammatory medications, immunosuppressants, all of them have terrible side effects, especially chronic use of them, and one of those is actually loss of fertility, which I will discuss a little bit later. So the pathogenesis of SLE is not completely understood. This is the most likely proposed mechanism, but it begins with a loss of self-tolerance. Okay, so usually there's some sort of genetic predisposition, which again I will discuss later on in the presentation, but that will be combined with some environmental or epigenetic factor that's going to cause exposure to the body of nucleic acids. Okay, so what happens then is instead of normal clearance of apoptotic cells, these nucleic acids are released into the system, and most likely the antigen presenting cells, the dendritic cells, are going to get exposed to those. They're going to signal to our T cells that we've got a pathogen here. It's not supposed to be here. I don't recognize it as self. And that's what's going to start that autoimmune cascade. T cells are then going to talk to B cells to produce antibodies against those nucleic acids. We call them anti-nuclear antibodies. And the whole immune cascade is going to go from there. It's going to cause systemic inflammation, which can lead to tissue damage and fibrosis all over the body. So this is where vitamin D comes in that these immune cells, the dendritic, the T, and the B cells, all have that vitamin D receptor. So what vitamin D can do for dendritic cells is basically you have your normal dendritic cell, which will get activated and mature into a plasmacytoid dendritic cell. Vitamin D can stop that process from happening, which causes a decrease in pro-inflammatory cytokine production, such as the interferon family, as well as it can signal to T cells to, hey, we need to stay in an anti-inflammatory state, rather than we need you to go pro-inflammatory, which is going to lead to a better balance between our T regulatory cells, our T regs, which are anti-inflammatory, and our Th17 T cells. So those are our pro-inflammatory. All right, so we need a balance between these two different CD4 positive T cell subtypes to maintain proper inflammation, proper immunity throughout the body. Now, when that dendritic cell becomes that plasmacytoid cell, it can signal to the T cells to become pro-inflammatory, more IL-17 production, that's that pro-inflammatory cytokine, more interferon production. So all those pro-inflammatory cytokines here are signaled in red, and that's going to decrease our anti-inflammatory cytokine production, those in the green, which will then affect how that T cell talks to a mature B cell. Okay, so less T cell proliferation, which is a regular dendritic cell versus that plasmacytoid dendritic cell, will also mean less crosstalk between T and B cells, less anti-nuclear antibody production. Okay, so vitamin D can affect at every single level here what is the inflammatory response, the immune response produced by the body. The literature supports this. If we look at dendritic cells, like I said earlier, that vitamin D can block the full maturation, which will decrease the pro-inflammatory interferon alpha output and increase anti-inflammatory IL-10 production. It can overall lower down that inflammation throughout the body. It will also affect what type of subset that T cell becomes, whether it's a T regulatory cell or a Th17, which will affect our inflammatory profile. So in vivo, Talat et al. Saw that with an increased presence of Th17 cells, this was associated with a vitamin D deficiency in many people with SLE. Now looking at B cells, increased B cell proliferation and hyperactivity, so that's our anti-nuclear antibody production, was also associated with decreased levels of vitamin D in vivo. Which leads us to our genetic and epigenetic factors. So like I said earlier, there's usually a genetic predisposition, and over the last 50 years, several genes have been identified which have led to a predisposition for SLE. However, it is the epigenetic and environmental interactions with the genes that seem to be the more likely cause of SLE development. The three most common things seen in SLE are DNA methylations, you've got RNA-based mechanisms, so microRNAs is what I'm going to touch on today, as well as histone modifications. So if you remember back to our lower level biology classes, those histones wrap the DNA, keep it coiled tightly in that chromatin structure, and whether or not the DNA is wrapped around that histone will allow it to be transcribed. So if it's wrapped up tightly, it cannot be transcribed into RNA. If it's free and loose, there's that possibility. So modifications with how that DNA is wound and what proteins, cytokines, chemokines are produced depends on that histone modification. So in the literature, as I said with genetics, over 50 genes have been identified which influence SLE development. However, in studies of monozygotic twins, so basically the same DNA, there was found to only be 14% disease concordance, which is why we think that it's more influenced through epigenetic factors. So things I focused on are looking at miRNAs. So Liu et al. Found 6 microRNAs that were to be lower in patients with SLE. After validation, 2 of these were significant, and those levels positively correlated with vitamin D levels in those patients. If we look at DNA methylations, in the study with monozygotic twins, hypomethylation of interferon regulating genes was found in CD4 positive cells, monocytes, granulocytes, and B cells in the twin with SLE. In that same twin, hypermethylation was seen in B cell promoter regions, which will have implications for that anti-nuclear antibody production. Histone modification was important through toll-like receptor 2 in those CD4 positive cells. In these cells, histone modifications of methylations and acetylations were on the IL-17A gene, which means that they're, in this case, probably producing more IL-17 and leading towards a phenotype polarization of that Th17 pro-inflammatory T cell. So that brings us to kind of how SLE is treated and what vitamin D can do for that. So currently, SLE is treated through non-steroidal anti-inflammatory drugs. So you've got stomach bleeding, kidney problems, and increased risk of heart problems as side effects of chronic use of those. Side effects for corticosteroids, weight gain, easy bruising, osteoporosis, diabetes, high blood pressure, the list goes on. The most promising biologic right now is belimumab, which still produces nausea, diarrhea, and infections. And then, of course, you've got immunosuppressants trying to decrease that inflammatory response, and that leads to increased risk of infection. Most notably, as I mentioned earlier, decreased fertility and an increased risk of cancer in women of childbearing age. That's our age. I mean, that's when we want to have kids and don't want to have cancer. So these things have nasty side effects, so it's obvious we need a different option out there. Which vitamin D supplementation, as I've suggested through this evidence, has the possibility to have a huge impact on SLE treatment. However, there are some studies that have shown no effect, even with large levels of supplementation. So if you'll remember the RDA value for vitamin D is 600 IUs per day. So in the study by Arnau et al., they supplemented with up to 4,000 IUs and still saw no effect on interferon alpha levels in the blood or gene expression on B and T cells after microarrays. Andrioli then also looked at a 24-month crossover study with vitamin D repletion. So they did two strategies, one with a huge hit of something like 80,000 IUs and then a maintenance over the next couple months. The other strategy was just a higher level supplementation over that year. And both strategies failed to have any type of change on disease activity or serum markers. However, on the flip side, we've got positive effects. So the study by Marino et al., they looked at the type of T cell subsets that were produced after vitamin D supplementation, and they saw increases of that T regulatory, decreases of Th17 levels, so we're moving towards an anti-inflammatory profile here. However, they didn't look at data on clinical symptoms. The most promising study I saw was in juvenile onset SLE, so study of patients under 25 years old, supplementation of 50,000 IUs per week. If you do the math, that's about 7,000 per day, which led to repletion of about 70% of the patients and a decrease in fatigue, clinical symptoms, and SLE disease activity index. So it's kind of how we look at how severe the score is. So this kind of leaves the possibility that maybe vitamin D supplementation can be more effective in younger people when that immune system's getting out of control there. The big point of all of this, though, is there were very few negative side effects in any of these studies, even with very high levels of vitamin D supplementation. And I mean, if you look in the juvenile SLE study, that's 7,000 IUs per day, and it only repleted 70% of patients. So that's very interesting to look at what's happening there with the vitamin D and how it's being processed by the body. So I guess the takeaway from this, though, is that, vitamin D, there aren't enough studies to show that it will help, but these studies show that even in high amounts, it's probably not going to hurt. So to bring that into conclusion, SLE is an autoimmune disease that's characterized by systemic inflammation, but there's currently no cure. The pathogenesis is unknown, but research does show that a combination of genetic, epigenetic, and environmental factors will play a role in its pathogenesis and development. And I've bolded that epigenetic and environmental factors because those seem to be the most important, but also the things that we can maybe have some control over. Immune dysregulation involving dendritic cells, T cells, and B cells lends towards a pro-inflammatory milieu and can be impacted by vitamin D, as all those cells contain that vitamin D receptor. And studies show that vitamin D does have an influence on those cell types. However, current treatments have many adverse side effects, and studies with vitamin D supplementation have mixed results. But again, with these studies, there were very few negative side effects seen. So I just want to say thank you for your attention. There are my sources, and that is all.